Bismillahirrahmanirrahim. First, we discuss today about muscle dystrophy. In muscle dystrophy, there is a progressive muscle weakness, and there is also degeneration of muscle. Muscle tissue is replaced by fat tissue and collagen. So muscle tissue is replaced by fat tissue and collagen. There are different types of muscle dystrophy. One important type is called Duchenne muscular dystrophy. Duchenne muscular dystrophy. It is an important type of muscular dystrophy, Duchenne muscular dystrophy. This disease is present in males. It is X-linked recessive trait. So X chromosome linked recessive trait. So it is only present in males, not in females. The disease starts in early childhood. Say the age of 5 to 10 years. And then at the age of 12 years, the patient is on wheelchair. At the age of 12 years, the patient is on wheelchairs. And most of these patients die at the age of say 30 years because of the respiratory failure. So because of the respiratory muscle failure, most of these patients die around about the age of 30 years. I told you it is X-linked recessive trait. In this condition, the gene which controls the formation of dystrophin, is mutated. So mutation of gene which controls the formation of dystrophin is mutated. So there is a deficiency or mutation of the protein dystrophin. So because of mutation in the gene which controls the synthesis of dystrophin, there is deficiency of dystrophin or there is mutation of dystrophin. And this results into the Duchenne muscular dystrophy. So this protein dystrophin, it connects the actin with the protein in the muscle's cell membrane. So dystrophin, it connects actin with the muscle cell membrane. Right? This is the dystrophin, connecting the actin with the muscle cell membrane. A mild form of Duchenne muscular dystrophy is Becker muscular dystrophy. So a mild form of this disease is Becker muscular dystrophy. So this was about the muscle dystrophy or Duchenne muscular dystrophy. What is a single muscle twitch? Single muscle twitch. This is a single muscle twitch. Now, when action potential reaches to the muscle, there is a brief contraction followed by relaxation. So, simple muscle twitch is a brief contraction followed by relaxation in response to the action potential. So, you see, a brief contraction followed by relaxation in response to an action potential. Refractory period in which the tissue does not respond to second stimulus after the application of the first stimulus. Muscle is refractory electrically during the depolarization phase and first 1/3 of repolarization during action potential. We know the spike potential, action potential, with rapid upstroke followed by rapid downstroke. So during depolarization of, that is rapid upstroke, and first 1/3 of repolarization, the muscle is electrically refractory. The muscle is electrically refractory during the depolarization and first 1/3 of repolarization. The contractile mechanism in the muscle does not have refractory period. The contractile mechanism in the muscle does not have refractory period. So summation can occur. Summation of contraction can occur. What is summation of contraction? Adding up of muscle twitches or contractions. So summation is adding up of contraction or muscle twitches. Summation of contraction or muscle twitches is of two types. So two types of summation of contraction or muscle twitches. The first one is multiple motor unit summation, also called spatial summation, or multiple motor unit summation, also called spatial summation. It means that multiple motor units are excited and these contract simultaneously. So multiple motor units contract simultaneously, not one motor unit. Multiple motor units contract simultaneously, and this leads to summation, which is called spatial summation. So keep in mind, multiple motor units or increased number of motor units contract simultaneously, and this results into summation that's called spatial summation. The other summation is frequency summation. The individual motor unit is stimulated by increased frequency of stimulation. repeatedly. Right? So the individual motor unit is excited repeatedly. One motor unit is excited repeatedly by increased frequency of stimulation. And this results into frequency summation or temporal summation. This frequency summation or temporal summation. You see, these are single muscle twitches, right? The muscle is stimulated repeatedly, and this results into, of course, in this figure, the individual single muscle twitches. And then we increase the frequency of stimulation. We increase the frequency of stimulation, and this results into summation or fusion of twitches. So we stimulate the motor unit with the increased frequency of stimulation, and this results into fusion of twitches. Fusion of twitches. And ultimately what you get, this is tetanization or complete tetanus, right? So you just say you apply the, stimulate the individual muscle units, you increase the frequency of stimulation, and ultimately there will be complete fusion of twitches, muscle twitches, and this is called the complete tetanization. Complete tetanization. You can see here this is the frequency of stimulation of stimuli, that is, say, 5 stimuli per second, 10 stimuli, 15, 20, 25, 35, say 40, 45, right? Now, you start with, you apply rate of stimulation or frequency of stimulation, say 5 to 10 stimuli per second. With this frequency, you can see the individual muscle twitches. You can see separately the individual muscle twitches. So at a rate of frequency of stimulation of 5 to 10 stimulation, there will be separate individual muscle twitches. But when we increase the frequency of stimulation, there will be incomplete fusion of muscle twitches. There will be incomplete fusion of muscle twitches. I mean, there are periods of incomplete relaxation between the fused twitches. So periods of incomplete relaxation between the fused muscle twitches. And then finally, what you get, say at a frequency of stimulation of 40 to 45, this is sustained contraction, you see? Sustained contraction, which is called tetanization or complete tetanization. So at a frequency of say above 40 stimuli per second, there will be complete tetanization, there is complete fusion of twitches, there is sustained contraction without relaxation. So above the frequency of stimulation of 40 stimuli per second, there will be complete fusion of twitches, there will be complete tetanization, there will be sustained contraction without relaxation. It is called complete tetanization. Complete tetanization. The frequency at which complete fusion of twitches occur or complete tetanization occurs, it is called the critical frequency or tetanizing frequency. So frequency of stimulation at which complete tetanization occurs, at which complete twitches fusion occur, it is called tetanizing frequency or critical frequency. This is the critical frequency or tetanizing frequency, which results into complete tetanization, complete fusion of twitches, or sustained contraction without relaxation. This is the complete tetanization. Keep in mind during summation and tetanization, there is increased muscle tension. You see, during summation or complete tetanization, there is increased muscle tension. You see, this is the individual muscle twitch or single muscle twitch. This is the tension of the single muscle twitch. Tension of the single muscle twitch. And what we see here, in complete tetanization, the muscle tension is increased, say, 4 to 5 times. 4 to 5 times increase in the muscle tension during complete tetanization. So this was about the tetanization and the fusion of muscle twitches. Two-type fusion, multiple motor unit fusion or summation, and that is called the spatial summation. And then comes the frequency summation or the temporal summation, right? And then we discuss about the tetanization, that is the complete fusion of muscle twitches without relaxation. So sustained contraction without relaxation. What is the trapping or staircase phenomenon? Trapping or staircase phenomenon. When stimuli are applied to the muscle at a frequency below the tetanizing frequency, when stimuli are applied to the muscle at a frequency below the tetanizing frequency, there is progressive increase in the muscle tension till it becomes constant, till there is a plateau. So when muscle is stimulated by a frequency of stimulation below the tetanizing frequency, there is progressive increase in the muscle tension till the muscle tension becomes constant, uniform. Right? It shows plateau. And this is called the staircase phenomenon or trappy phenomenon. So staircase phenomenon or trappy phenomenon. So staircase phenomenon or trappy phenomenon. Staircase or trappy phenomenon. Right? Now this staircase or trappy phenomenon, that there is progressive increase in the muscle tension developed till it becomes uniform or constant in the form of a plateau. This is called the staircase phenomenon or trappy phenomenon. A staircase phenomenon is due to accumulation of calcium ions in the sarcoplasm. So trappy or staircase phenomenon is due to accumulation of calcium ions in the sarcoplasm. So this was about the staircase or trappy phenomenon. Next, about the muscle tone. What is muscle tone? Muscle tone is continuous state of partial muscle contraction at rest. So continuous state of partial muscle contraction at rest is muscle tone. So continuous state of partial muscle contraction at rest is the muscle tone. Muscle tone mechanism involves the stretch reflex, receptors which are called muscle spindles, and also the gamma efferent discharge. Muscle tone mechanism involves the stretch reflex, the receptors which are called muscle spindles, and also the gamma efferent discharge. We'll discuss these later in detail. Muscle tone is controlled by a center in the upper brainstem that is called bulboreticular facilitatory area. So muscle tone is controlled by a center in the upper brainstem which is called bulboreticular facilitatory area. So bulboreticular facilitatory area is present in the upper brainstem and it controls the muscle tone mechanism. So this was about the muscle tone. Next is rigor mortis. R-I-G-O-R, rigor mortis, M-O-R-T-I-S. So rigor mortis, you must have seen in dead bodies, right? So after many hours of the death, the dead body becomes rigid and develops sustained contraction. So many hours after the death, dead body becomes rigid and develops sustained contraction, and this is called rigor mortis. So many hours after death, dead body becomes rigid and develops sustained contraction, which is called rigor mortis. So rigor mortis, what is the mechanism? Why does it develop? Now after death, ATP is not available. So when there is no ATP, myosin heads cannot be detached from the active sites on the actin filament. After the death, ATP is not available. So myosin head cannot be detached from the active sites on the actin filament. Or you can say that the myosin head remains attached to the active sites on the actin filament. Myosin heads remain attached to the active site on the actin filament. So when these are not detached, these remain attached. So this results into rigidity or sustained muscle contraction. That is the rigor mortis. How does rigor mortis disappear? How does rigor mortis disappear? Right. After about 15 to 25 hours, rigor mortis disappears due to autolysis of muscle proteins by lysosomal enzymes. So after about 15 to 25 hours, 15 to 25 hours, rigor mortis disappears due to breakdown of proteins, proteolysis, by the lysosomal enzyme. So lysosomal enzymes in the dead body, these come out of lysosomes, and these called autolysis of the muscle proteins. So rigor mortis disappears due to the autolysis of the muscle protein by lysosomal enzymes. Increased temperature will fasten the appearance of rigor mortis and disappears also. So increased temperature will accelerate the process of appearance of the rigor mortis, and it also disappears rapidly if there is high body temperature. Next, we discuss about electromyography. Electromyography is the recording of electrical activity of the muscle. So electromyography is the recording of electrical activity of the muscle. And this is called electromyography or EMG. So EMG can be recorded on cathode ray oscilloscope. EMG can be recorded on the cathode ray oscilloscope. EMG is recorded by placing small metallic electrodes on the skin overlying the muscle. So EMG can be recorded by placing small metal electrode on the surface of the skin, overlying the muscles. Or it can be recorded by inserting needle electrodes into the muscle. It can be recorded by inserting needle electrodes into the muscle. By needle electrodes, we can record the electrical activity of the individual muscle fiber. So with the help of the needle electrodes, we can record the electrical activity of the individual muscle fibers. In the electromyogram, the record is called electromyogram. We can see fibrillations, we can see fasciculation. So we can see fibrillations and we can see fasciculation. Fibrillation is invisible, fine contraction of the individual muscle fiber. So fine, non-visible contraction of the individual muscle fibers, which can be recorded in the EMG, is called fibrillation. So fibrillation is fine, non-visible contraction of the individual muscle fibers, which can be recorded, which can be seen in EMG. Fasciculations are irregular, jerky contraction of bundles of muscle fiber. Fascicles of muscle fibers, and these contract, these are called fasciculation. So jerky, irregular contraction of the bundles, the fascicles of the muscle fibers is called fasciculation. Fibrillation and fasciculations can be recorded in cases of low motor neuron lesion. So in low motor neuron lesion, you can record fibrillations and and fasciculation. EMG, electromyography. Electromyography can differentiate between nerve disease and muscle disease. So, with the help of EMG, we can differentiate between a nerve disease and a muscle disease. So, we can differentiate between the nerve disease and muscle disease in electromyogram. You see, this is the EMG during contraction. When muscles contract, and of course when muscles are relaxed, there won't be activity in the EMG. When muscle is relaxed, there is no activity in the EMG. This is the muscle when contracted. Right? This is the pattern in the normal muscle when it is contracted. And this is the recording in the EMG when there is myopathy, when there is muscle disease. When there is myopathy or muscle disease, this is the recording in the EMG. Myopathy. You see, the amplitude of waves is low in the EMG of myopathy. And this is neuropathy. You see, this is the pattern in the EMG when there is nerve disease or when there is neuropathy or nerve disease. This is the pattern in the EMG. Right? This is the activity when muscle is not contracted.